Yes, yes, sir. We are live now.
Madam, we are live now. Shall we start?
Yes, we can start.
Can we start, ma'am?
Okay.
Yes.
So, yes. So, good evening, doctors and all the participants. I, Shumon, on behalf of Shield Healthcare, welcome you all in today's session on pregnancy and cancers organized by Safe Motherhood Committee, the Obstetrics and Gynecological Society of Southern India. So I welcome all the delegates and the chairpersons, office bearers, speakers, and all the panelists and all the dignitaries. So let me introduce our today's MOC, Dr. Varani Madam. Madam is Madam did her MBBS DGO DNB of STEM Gynae. And Madam was a member Safe Motherhood Committee of OGSSI 2023, and she did her DGO from Madras Medical College and DNB from Apollo Hospital, Chennai. She was the gold medalist in MBBS and second position second in DGO from Tamil Nadu MGR University. And in terms of academic activities, Madam presented many papers in national and international conferences and published many articles in journals of world repute. And she received award for outstanding performance in maternal and child health care, Tamil Nadu Ministry of Health and Family Welfare in the year 2018, Best Resident Award 2022, and Best Paper Publication Award 2023 from Apollo Hospitals. So with this short introduction, I request Madam to take over the session. And meanwhile, I request all the participants for your active participation, and please post your queries on the chat box of the page so that with the session they can. Thank you very much, Madam, and over to you for further questions.
I would like to start with a Tirukural, which says, Tham inguruvadu ulagingura kandu, Thamuruvar katrarindar. True to the words of Thiruvalluvar, knowledge is best cherished when it is shared. And today we are grouped to cherish the knowledge that we have acquired and to venerate the same to everyone. Good evening, one and all. I'm Dr. Varani. I'm a member of the Safe Motherhood Committee of OXI, and I take immense pleasure in welcoming one and all to today's webinar on pregnancy and cancers organized by Safe Motherhood Committee of OXI. I will be taking you through today's sessions. We will begin with a welcome address by Dr. Jayarani Kamaraj, President OXI. Madam, she's a senior consultant of reproductive medicine and director Akash Fertility Center, Chennai. Adding more feathers to her cap, she's also treasurer TAPISAT, associate secretary and advisory council member, World Association of Sexual Health, a gold medalist, and with numerous awards in her kitty, like Best Doctor Award and Women Achievers Award, Madam is here to deliver the welcome address. Good evening, Madam.
Am I audible?
Yes,
Yes, ma'am.
அனைவருக்கும் மாலை வணக்கம். Thank you, Bharani, for this nice introduction. On behalf of OXI, I welcome all the senior OXIans and my dear friends for this webinar on pregnancy and cancer. We all know it is a real dilemma for us when you come across any women with pregnancy and cancer. It's a real challenge for the obstetricians who look into the maternal health as well as the fetal health. And it is a real challenge for us how to manage and how to take care and how we have to manage such situations. So for this, we have with us all the senior faculties here. And on behalf of OXI and the Safe Motherhood Committee, I welcome the senior faculties here to talk on this wonderful content of this pregnancy and cancers. I welcome all the delegates. I welcome all the senior fraternities and also all the youngsters who are there dynamically participating in our committee activities. And as for all, as nicely pointed out by Barney, it's a knowledge is power, and getting your experience and expertise in this field to be shared is a real blessing. So with these words, I welcome you one and all for this wonderful webinar, and over to you, the MC and the chairpersons, for further contact. And I felicitate the Safe Mother Committee headed by Rajeshri. You are doing a wonderful work, and it is a real appreciable, tremendous work. And I thank Shield also for giving a frequent platform to all our activities. And I thank one and all, and we welcome you again. Thank you so much.
Thank you, Jayarani ma'am. Thank you.
We will now proceed with the OXI prayer. I invite Dr. Kundavi Shankar, ma'am, Honorary Secretary OXY. She's a senior consultant in IRM MMM, specialist in reproductive medicine and laparoscopy. She's an active member of various obstetrics and gynecology societies throughout the country and invited faculty in many conferences. I request you, ma'am, to present the OXY prayer.
Thank you, Dr. Bharani, and thank you, God. In humility we gather, in gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Over to Rajshri.
Thank you, Madam. Bharani, you can take over.
Yes, ma'am. A quick sneak peek into what we're going to do today. We're going to have the first session, which will be an update on cervical cancers in pregnancy, followed by a dialogue on pregnancy and breast cancers, an oration on gestational trophoblastic neoplasia, and last but not the least, a panel discussion on adnexal masses in pregnancy. We have two esteemed experts, Dr. Shanti Gunasingh Madam and Dr. Ramanan Sir, who will share their pointers at the end of the talks. Dr. Shanti Gunasingh Ma'am, past president of OXY, former director of IOG and KGH, and HOD of K-Pop Medical College. She served as project director, Center for Excellence for Tubal Microsurgery. She has a penchant for learning and is an exemplary teacher and mentor. Extremely happy to have you here as our experts, ma'am. Dr. Ramanan Sir, he's the director, Madras Cancer Care Foundation, and senior consultant in medical oncology at Apollo Cancer Center. He's a founder trustee of CAMCare, Cancer Research and Relief Trust. He has many publications at peer-reviewed journals to his merit. With a vast experience in the field of medical oncology, he's a befitting expert for us today, and he will also double up as a panelist for the panel session later. We shall have the expert comments after the first three sessions. Questions will also be answered then. So I request all the delegates to type your questions in the chat box, and we will take them ahead of the panel discussion. We'll now begin with our first talk. This is by our very own able chair of Safe Motherhood Committee, the enthusiastic Dr. Rajshri ma'am. She's a consultant at Sri Swasthya Clinic Center for Women and Child, executive member of OXY, with high-risk obstetrics as her special interest. And she also has written a chapter in the textbook for management of labor. She will present a much-needed talk today. It is said that at least 1 to 3% of women who are diagnosed with cervical cancer today are either pregnant or in their postpartum period. So we will now begin with an update on cervical cancers in pregnancy. Over to you, ma'am.
Thank you, Bharani, for the kind words. Can I share the screen now?
Yes, ma'am.
Yeah. I have to go to slideshow. Is it on slideshow? I'm not able to see the slideshow. Yeah, okay, I'll go here. Thank you, Bharani, for the kind introduction. We all know that both cancer and pregnancy are life-changing events. And if both of them occur together, then it is a huge stress, not only for the pregnant woman and her partners and her family, but also to the obstetrician who is treating her. Despite advances in cancer management for pregnant women, many important questions remain unanswered by evidence-based information. Therefore, this update on cancer cervix in pregnancy is chosen for a topic today. Though cancers in pregnancy as such is rare, commonest gynecological malignancy diagnosed during pregnancy is cervical cancer. So the incidence of cervical cancer is 0.1 to 12 per 10,000 pregnancies. Its relative risk is lower during pregnancy than in non-pregnant women. And the progression of pre-invasive to invasive disease during pregnancy is 0.4%. With the introduction of HPV vaccination for school children, a 55% reduction in cervical cancer rates in women aged 25 to 29 years is predicted. And this is a good news. Should we do cervical screening in pregnancy? Do we routinely screen? No, we do not. But pregnancy is not a contraindication to do a smear test. Cytology, follow-up cytology should be done after treatment of cervical glandular intraepithelial neoplasia and CIN 2 and 3 with involved or uncertain margins. Next, we'll go to the diagnosis of cervical cancer in pregnancy. Cancer-related symptoms like painless vaginal bleeding, pelvic and low back ache, and urinary symptom mimic pregnancy complications. Therefore, beware. When pregnant women present with these symptoms, they should not be ignored. All women presenting with bleeding in pregnancy should be examined under good light. A speculum should be inserted and the cervix should be visualized. If a cervical abnormality is identified, then they should be urgently referred to an experienced colposcopist. What about colposcopy in pregnancy? It is safe during pregnancy. And the aim of colposcopy is to exclude invasive disease and defer biopsy until after delivery. It has to be done by a colposcopist who has a high degree of skill, as the changes in pregnancy can mimic neoplasia. These will include increased cervical mucus, cervical hyperemia, gland prominence, and eversion of columnar epithelium. Following colposcopy, if an invasive disease is suspected, then an adequate biopsy is crucial. Excision biopsy or punch biopsy, what do we do? Punch biopsy cannot reliably exclude invasion. Therefore, we have excision biopsy is preferred. While doing excision biopsy, use of diathermy can lead to hemorrhage in 25% of cases. So it can lead to a lot of bleeding. Therefore, it should be preferably done in operation theaters where you have facilities to manage the hemorrhage. So once we have diagnosed, the next step is the staging of cervical cancer. The FIGO 2080 staging system for cervical cancer can be employed, same as a non-pregnant, can be employed for pregnant women also. The staging modalities will include MRI is the first choice, CT second choice, ultrasound to look at the maternal kidneys, and we must remember that hydronephrosis is physiological in 90% of pregnancies. X-ray test should be done when lung metastasis is suspected, and laparoscopic pelvic node dissection helps in planning management. Staging pelvic node dissection helps in planning management. So first we'll look at the role of MRI. It's the first line for staging in cervical cancer in pregnancy, that is the MRI of pelvis. It is safe at any gestation as there is no ionizing radiation. If we suspect distant metastasis, then an abdominal MRI can be done. Pregnancy itself poses challenges when interpreting the MRI results, because the dilated pelvic veins can be misinterpreted as pelvic adenopathy, and there could be a reduction in image quality because of fetal movements. The use of contrast is not essential in the staging of cervical cancer. Next, the role of CT. CT scans are usually contraindicated during pregnancy to avoid a dose of radiation to the fetus. If there is high suspicion of pleural or lung cancer, then the benefit would outweigh the risk to the fetus. If a CT scan is required, we have to limit the fetal exposure to the radiation. How do we do it? Minimize the length of scanning time, offer abdominal shield, and use low-dose radiation. Next, the role of laparoscopic lymphadenopathy. Accurate nodal staging is essential to the prognosis and treatment. Stage 1 disease, lap lymphadenectomy, allows for risk stratification. Positive lymph nodes need for urgent treatment. Negative lymph nodes may allow time for fetal maturation. So performing a nodal resection after 22 weeks of gestation is not recommended, right? And the role of sentinel lymph node biopsy in cervical cancer in pregnancy is yet to be studied adequately. So next, having done the diagnosis and staging, we will move on to stage-wise management of cervical cancer in pregnancy. Stage 1A1, without lymph vascular space invasion, between 14 to 20 weeks, the treatment is a cone biopsy. How do we do a cone? With either cold knife or laser. The cautery is not preferred because you have to avoid heat artifact, and we get a better depth and margin assessment from a single specimen. Once we have done the cone biopsy, we have to encourage vaginal delivery. For stage 1B1, 1A1 with lymphovascular invasion, stage 1A2 and 1B1, the gold standard will be radical hysterectomy with bilateral salpingectomy, as it will prevent the spread of prevent epithelial tumors later on. It will also mobilize the adnexa and prevent formation of hydrosalpinx following chemotherapy and radiotherapy and addition. So bilateral radical hysterectomy, bilateral salpingectomy, with or without bilateral oophorectomy, depending on the desire to retain the future fertility, and a bilateral pelvic lymph adenectomy. This is the gold standard treatment for the stages 1A1 with lymphovascular invasion, 1A2 and 1B1. So depending on the gestational age, if it's less than 22 weeks, then lap staging pelvic lymph node dissection is done, staging lymph node dissection is done. And if the nodes are positive, then, and if the patient is willing for medical termination, then in situ radical hysterectomy or the gold standard treatment, or if it is in situ, gold standard treatment can be carried out. If the patient is not willing for termination of pregnancy, then neoadjuvant chemotherapy is given. You deliver at maturity, that is 34 to 36 weeks, and then plan for radical hysterectomy. So if the lymph node sampling is negative, then we go ahead and trachelectomy, simple trachelectomy, though said in text, is not routinely done. I have not seen a routine trachelectomy being done because the blood loss is more and the risk of preterm labor is 20 to 30%. So we generally tend to delay treatment till after delivery. For stage 1B2, the size of the lesion is large. In 1B2, it is about 2 to 4 centimeters. Therefore, there is no role for staging lymphadenectomy here because anyway, we can't do a conservative surgery. Depending on the gestational age, if it is less than 22 weeks, then we do the radical hysterectomy with fetus in situ. But if the pregnant woman refuses for termination, then we give neoadjuvant chemotherapy followed by surgery after delivery. If the gestational age is greater than 22 weeks, then neoadjuvant chemotherapy is given and cesarean section is done at maturity, which is 34 to 36 weeks with concurrent radical hysterectomy. So why are we talking in terms of cesarean section and not vaginal delivery? What are the risks of normal vaginal delivery in this situation? First, the size of the lesion is large and it can obstruct the birth canal. 2, there can be excessive bleeding. And it is known that the tumor recurrence is more at the episiotomy site than the abdominal incision. Therefore, cesarean section is preferred and it is done at 34 to 36 weeks. If the tumor size is large and the lower segment cannot be visualized, then a classical cesarean is done. But we should be careful and we should beware of the hemorrhage at the incision site because of extreme vascularity, and we must be prepared to tackle it. Always, the placenta has to be sent for histopathology to confirm that there is no evidence of spread. Stage 1B3 and above, neoadjuvant chemotherapy is given irrespective of gestational age. And then following delivery at 34-36 weeks, at maturity at 34-36 weeks, cesarean section with concurrent radical hysterectomy or radical chemoradiation is given based on the initial staging and also the response to the neoadjuvant chemotherapy. If the response is good, then we can give radical chemoradiation. So let us look at the safety of the chemotherapy and pelvic RT. So neoadjuvant chemotherapy is contraindicated in the first trimester. It is safe after 14 weeks. The dose is the same as non-pregnant women and it depends on the weight. Carboplatin paclitaxel is preferred to cisplatin paclitaxel, and in view of reduced nephrotoxicity and ototoxicity, 3-weekly regimen is preferred to weekly regimen, as a pregnant woman can be monitored closely. There should always be a 3-week gap prior to cesarean section for maternal and fetal bone marrow recovery. Chemo should not be given after 35 weeks, as the woman will become neutropenic if she goes in for preterm labor. Regarding pelvic RT, it is done for stages greater than 1B3 following cesarean section. And prior to radiation therapy, counseling is very, very important regarding the damage that it will cause to the ovary. And therefore, if the pregnant woman is desirous of pregnancy, future pregnancy, she should be counseled by a fertility specialist. Ovarian transposition can be done, and for oocyte retrieval later on, and also to prevent premature menopause. Regarding the uterus, following radiotherapy, the uterus will not be able to go through a term pregnancy, and therefore, even if oocyte retrieval is done and oocytes are available, they should be counseled regarding surrogacy. That is very important. Next, the multidisciplinary team approach is very, very important in treating these women. And this should comprise of gynae-oncologist, medical radiation oncologist, radiologist, histopathologist, neonatologist, psychologist, and fetal medicine specialist. So it should be made sure that the physiological changes making the diagnosis and staging challenging should not cause any detrimental effect for the care of the patient or the final prognosis. So we require a multidisciplinary care to make sure that she is managed ideally. So breastfeeding, a period of lactation following a stressful pregnancy, can be of psychological benefit to the women, and 14 days gap from the last chemotherapy session is advised for the drug to be cleared from breast milk. It is contraindicated with ongoing chemotherapy, as it can cause neonatal leukopenia. Psychological care is a very, very important part of the care. Counseling should be offered to both the affected woman and her partner. Extensive education on the necessary medical steps, implications and outcome of the pregnancy, and long-term effects on the physical and cognitive health of the offspring should be discussed in detail. And if you have support groups, friends who have gone through this pregnancy, cancer during pregnancy, we'll have to involve them. They should have talks so that they will serve as support for the family. The possible psychological effects of radical surgery before performing the surgery, which will include depression, loss of sexual pressure, and the future childbearing ability, should also be discussed with the couple before going ahead with the radical surgery. Thank you. Thank you for the patient listening.
Thank you, ma'am. We'll move on to our next session. It's a conversation, and you can call it a friendly banter between two friends, or a talkathon on practice points. We have the next session, which is a dialogue between Dr. Shravya and Dr. Asha on pregnancy and breast cancers, what we need to know. What we do know is that many women are choosing to delay their pregnancy nowadays. And with breast cancer being most commonly seen at 32 to 38 years of age, there is a likely increase in the detection of breast cancer during pregnancy. If I can have the CV of Dr. Shravya and Dr. Asha.
Sahiti? Sahiti, are you there? The CVs, please.
CV of Dr. Shravya and Dr. Asha.
Madam, just
So while he's trying to.
Madam, just 1 minute.
Here, Dr. Shravya, she's a consultant at Apollo Women's Hospital, Chennai. She did her clinical fellowship at St. George's University, London, and fellowship in minimal access surgery at Mumbai. She was awarded Dr. Savitri Subramaniam Gold Medal for Best Outgoing Student in 2016. And if I may take the liberty, she's also the Best Senior and Best Work Buddy. Along with her to tango is Dr. Asha Reddy, Consultant Oncoplastic Breast Surgeon, Chennai Breast Center and Apollo Hospitals. She did her HDNI fellowship in breast onco surgery from Tata Memorial Hospital, MCH in breast oncoplastic surgery from United Kingdom. As a fellow of European Board of Surgery and Breast Surgery. Pregnancy and breast cancer, what we need to know.
Yeah. Yeah, is it clear?
Yes, ma'am.
Yeah, great. All right.
A very good evening to everyone. Thank you for this opportunity to present today. So Dr. Shravya, you had sent a patient over 2 days ago with a lump in the breast, and I know that you are concerned that it could be cancer. Unfortunately, the biopsy has turned out to be a cancer.
That's terrible to hear. I know that the breast cancer rates are really increasing, and we are seeing quite a few pregnant women with breast lumps. So it is important to know how we'd further go about it. And so let me just delve into it further. So it is defined as breast cancer during pregnancy and up to 1 year postpartum. It's also known as gestational breast cancer. It occurs in almost 1 in 3,000 pregnancies and accounts for up to 3% of all breast cancers. It's the most common cancer during pregnancy. So for the benefit of everyone, let me give you more details of what exactly this patient, Dr. Asha, was talking about. So she was 32-year-old. She's 8 weeks pregnant. She came to the OPD with a lump in the left breast. She had no associated pain, no family history. And on examination, we actually found a 2 into 2 centimeter mobile but firm mass at the 2 o'clock position. So Dr. Asha, how would you actually go about this step by step?
So first we look at a triple assessment is what we call it. One arm is a clinical examination, which we've done, and we found a 2 centimeter lump. The next would be imaging. So generally we start off with an ultrasound in a pregnant patient. This helps us understand what the breast lump is, whether it's just cystic, whether it's fluid, whether it's some normal breast tissue, or it's possibly a lump which needs a further investigation. Now, when we find something on ultrasound, the next step we proceed with is a mammogram. Is a mammogram acceptable in pregnancy, Dr. Shravya?
Well, yes, we can use it when really necessary. We can use it with abdominal shield for the mother. And the mammogram, the radiation dose that's actually the baby is exposed to is 0.04 centigrade, which is not too much at all, to be honest. If you look at this chart, it explains that according to which gestation, the radiation dose and what kind of malformations are formed. So actually up to less than 1 centigrade is negligible risk. So you can go ahead and do that mammo.
Right. So the mammogram, if you can see here, there's a small lump in the breast, which you can see with the spiculated margins. It's a high dense mass. So this mammogram is suggestive of a cancerous lesion. So once the mammogram and ultrasound picks this up, the next step we do as the triple assessment is a biopsy. So we generally do an ultrasound guided core biopsy. FNACs are not recommended anymore. Core biopsy has many advantages over an FNAC. It, apart from giving us an accurate diagnosis, it also helps us understand the hormone receptors of the tumor, estrogen receptor, progesterone receptor, and HER2. And also there are some pregnancy-associated changes in the that occur in the breast, and an FNAC might not be able to distinguish this from a cancer. So gold standard is always a core biopsy.
All right. And would you work this patient up as for a metastatic part of it?
Yes. So generally, if a pregnant patient presents to us with a breast cancer, it is advisable to do a metastatic workup. In non-pregnant patients, we generally choose a PET scan or a contrast CT of the abdomen and thorax with a bone scan, but these two are not going to be done in a pregnant patient. So these are some of the investigations that we use as part of the metastatic workup. To look for any lung metastasis, we can choose a chest X-ray. For the abdomen and liver, we can choose an ultrasound, which is non-invasive. We can also choose an MRI of the abdomen, which is safe. And for when we look at a bone scan, we look at the risk versus benefit ratio, but probably better to do an MRI of the spine, which is a safer alternative.
All right. Okay. Thank you.
And so could you just maybe reiterate what are the investigations which are allowed and not allowed in pregnancy?
Yes, absolutely. So these are the investigations that are all right to do during pregnancy. So let me reiterate on the ones that are not allowed. So a big no would be to gadolinium enhanced MRI, because that is a category C drug, and radionucleotide bone scans, also PET scans, would be a big no during pregnancy.
Yes. So now we have a diagnosis of an early breast cancer. How would you discuss the pregnancy and treatment with the patient?
So the first and foremost thing is it would be an informed decision. The patient would have to be explained to regarding what exactly is happening, and all the options should be presented to her. She can choose to go ahead with the pregnancy or not. That would be entirely her choice after she is given the right amount of information about everything. So we would approach it as obviously a multidisciplinary approach, where we assess the disease extent, the gestational age, how we would further impact the pregnancy, and obviously, also minimizing the harm to the fetus as much as possible, but at the same time, making sure the mother's safety is the first and foremost thing. So how I would like to go ahead and manage this patient would be in the first trimester. Surgical management is absolutely all right. That's absolutely safe. The next thing is adjuvant management when it comes to chemotherapy. First trimester, chemotherapy is not the best way to go because it does cause serious malformations. Chemotherapy is reasonably safer in the second and third trimesters. And radiation and hormone therapy is completely to be reserved for postpartum. So can you explain a little more about the surgical management which would be able to do for this patient?
Right. So if we look at surgery, we kind of split it into treatment of the breast and treatment of the axilla. So for the breast, we have two options, lumpectomy or a mastectomy. And for the axilla, we have two options, sentinel lymph node biopsy versus an axillary clearance. So now the choice between a lumpectomy and a mastectomy. So for example, this patient is feasible for a lumpectomy, but that does have to go hand in hand with radiation. And since we want to avoid radiation during the pregnancy completely, and it may not be safe enough to wait and postpone the radiation completely, we may choose to go ahead with a mastectomy. Now, generally, when we do a mastectomy, especially in younger patients, we always offer the option of reconstruction. But again, in pregnancy, we want to keep the anesthetic time to a minimum, and we don't want to go into complex procedures. So possibly a simple mastectomy, reserving the option of reconstruction post-delivery would be the best option for surgery of the breast. Now, when we look at axilla, again, she's an early lesion. So generally, we do a sentinel lymph node biopsy first, and only if that is positive, we proceed with an axillary clearance. Now, the method that we do a sentinel lymph node biopsy, we usually use two dyes, blue dye and technetium. So blue dye is not safe in pregnancy. So we can do a sentinel lymph node biopsy with technetium alone, or we can add newer techniques like ICG, which can be used. So sentinel node is safe in pregnancy. And if it's positive, only then would we continue with an axillary clearance. So these would be the surgical options.
All right. Thank you for that, Dr. Asha. So let's move on to the next case. So there's a 27-year-old. She's a G2P1L1. She comes at 27 weeks pregnant with a swelling in the right axilla. On examination, we see a bit of redness and puckering over the skin involving the left breast, and there is significantly palpable left axillary lymph nodes. So this being said, obviously, how would you go about this?
So looking at the history and description of the examination itself kind of leads us towards a locally advanced breast cancer. Redness, skin involvement, and lymph nodes, these are all indicative of a locally advanced breast cancer. So we do similar imaging, biopsy, and metastatic workup like we discussed in the previous case, and then we'd have to decide on the further treatment.
Could you tell us a little more about the signs and symptoms that we have to look out for, during the examination, so we pick it up well as well?
So the signs and symptoms are similar. The only difference would be that in pregnancy, the breast is enlarged and there's physiological changes happening in the breast. So maybe being a little bit more attentive, and even smaller changes we can address with an ultrasound and then take it further if necessary. We look for similar symptoms like a lump in the breast, a pulled up nipple. Skin change is very common and to be aware of. Redness, rashes, any dimpling, and even any kind of nipple discharge should further be evaluated.
Okay, all right.
And so this being said, so if we look at pregnancy and breast cancer, how does pregnancy affect breast cancer and vice versa, breast cancer affect pregnancy?
Well, the effect of pregnancy on breast cancer, the prognosis is same. It's a stage for stage match. The reason there is a notion that there's actually, breast cancers are more aggressive in pregnant women. One is because of the pregnancy changes, there's always a delay in diagnosis. And two, obviously it's found in younger women. A majority of the breast cancers that occur during pregnancy are actually hormone negative, they're hormone insensitive. And termination of the pregnancy does not really alter the prognosis as such. Also, the long-term survival after breast cancer is not affected by the pregnancy, even when it's hormone sensitive. How breast cancer affects pregnancy? The disease itself has very little effect on the pregnancy, but the majority of the adverse effects are due to the anesthetic drugs, radiation, chemotherapy, and hormonal agents. So, Dr. Asha, we spoke about surgery. So what is the systemic therapy that, we can use during?
Especially in locally advanced breast cancers like this patient is going to require systemic therapy. So if we look at the indications of chemotherapy, in axillary node positive, tumors more than 1 centimeter. And again, depending on the hormone receptor status, we decide to give chemotherapy. So chemotherapy will fall under category D drugs though, however. Now, if the patient is HER2 positive, then we generally choose to give her Herceptin if it was a non-pregnant woman, but this is not allowed in pregnancy. It's a category X drug. And hormone therapy in ER and PR positive tumors is tamoxifen and letrozole, again, not permitted in pregnancy. So when we look at the chemotherapy drugs we generally use for breast cancer, anthracyclines and taxanes. Anthracyclines are quite safe. Taxane is kind of wishy-washy, but if required in high burden disease, it can be used. Like I mentioned, trastuzumab and tamoxifen not allowed. Okay. Dr. Shravya, any idea what trastuzumab and tamoxifen cause and why we shouldn't be using it?
So the reason we don't use immunotherapy is because it actually causes oligohydramnios, anhydramnios, and renal dysfunction in the baby. Also, hormone therapy causes ambiguous genitalia and Goldenhar syndrome. And chemotherapy, the way it affects sometimes is we should always make sure that the patient is well informed and discussed in detail regarding the possible complications with chemotherapy. Because it's not hunky-dory completely with chemo in the second and third trimester as well. We have to look for things such as intrauterine growth restriction, prematurity, low birth weight, and neutropenia, which can be maternal and fetal as well. So speaking of neutropenia, Dr. Asha, there is something called, colony stimulating, factor. What can we use it? Is it safe in pregnancy? What is it?
So yes, so it is used to prevent febrile neutropenia. We generally give it a couple of days before we give the chemotherapy. And it's indicated in high-risk patients, especially in those who are going to use dose-dense chemotherapy. So like I mentioned, the advantage is it's going to reduce the maternal febrile neutropenia, which is an important threat for both maternal and fetal survival. However, there aren't enough studies discussing the evidence to say that it's completely safe. There are some reports where it's caused physiological anemia, preterm labor, both motor developmental delay and cognitive developmental delay, as well as congenital malformations. But it is generally used because the risk of neutropenia is much higher.
Okay, all right.
And in terms of the pregnancy and chemotherapy, how would you proceed with that? When would you, any specific way you look at that?
So even when you give the patient chemotherapy, the patient can go up to full term. And as such, breast cancer in pregnancy is not an indication for cesarean section. Though it is important while managing the breast cancer, we monitor the pregnancy also really carefully with regular growth scans and more frequent if required, if there's any manifestation of intrauterine growth restriction. If we have to do an earlier delivery, we have to make sure that we do cover with steroids. And from the last chemotherapy, it is preferable if we at least wait 2 to 3 weeks to avoid the neutropenia path. So it's a bit safer for the delivery as well. And the placenta should be sent for pathology to pick up on any mets or any spread that is there.
Okay. So we've discussed about surgery and chemotherapy. Now, radiation we mentioned is not to be done during pregnancy. Could you elaborate on why?
So radiation therapy is completely contraindicated because there is a risk of scattered radiation as such to the fetus. What the possible complications that it can cause is pregnancy loss by means of miscarriage or stillbirth, malformations, growth retardation, and it can cause both mutagenic and carcinogenic effects.
Right. So we don't want to use radiation during the pregnancy.
Correct. Yes.
So let's move on to another case scenario. So we have a 35-year-old who we've just treated for stage 3 breast cancer. She's currently on chemotherapy, and she has now come to us with a UPT positive test, ultrasound showing 6 weeks. What would you recommend?
So here we have to look at it from the fetal part and the maternal part. Fetal wise, we would strongly advise her to terminate the pregnancy because chemotherapy is, especially in the first trimester, is prone to cause quite a few malformations, and it can lead to a miscarriage as well. And maternally, because she's in stage 3, she does need to continue with her treatment further. And when you look at the safety part of it, I think it would definitely be a safe option for her as well to, end the pregnancy. In fact, if you look at this article, there's an article which shows that chemotherapy with pregnancy with congenital malformations and the timing. This was done in 2021. 755 women were taken. And if you see when the major congenital malformations, when it was given less than 12 weeks versus more than 12 weeks, it was 21.7% versus 3%. 3%, is almost what the general population risk is. So it's quite a high risk comparatively. So, this child is quite prone to malformations and miscarriages.
Yeah, I think while on chemotherapy would be a difficult decision. So another case scenario is a 38-year-old woman known to have ductal carcinoma of the right breast. She's completed her surgery, chemo, radiation, and finished 2 years of tamoxifen. This is a very common question that our patients come to us with, especially when they're disease-free. Now, they want to think about having a child, especially when they don't have one yet, and sometimes even for a second child. What kind of counseling would you give them? And is it okay for them to get pregnant? And the medication they've taken in the past, is it fine?
All right. So a couple of things. It has to be a multidisciplinary team approach. It has to be something that fetal medicine, neonatologist, everyone is involved in. Because she has, she would have undergone chemotherapy and there's a high chance of cardiomyopathy with that. We have to do an echo during the pregnancy to make sure we catch on to it earlier. Ideally, it is best if they wait 2 to 3 years post-treatment, as highest risk of recurrence is then. And if you've done earlier, the cancer itself might recur during the pregnancy. If the patient is hormone positive, ideally tamoxifen is preferred for 5 years. But there is an option, once we explain the risks and benefits, that they can take a break after 2 years of tamoxifen, plan pregnancy, and decide on further treatment, hormone treatment after. But if she's on tamoxifen, then at least 3 months before planning conception, it has to be stopped because of its long half-life. If, unfortunately, she has a metastatic disease, we would discourage pregnancy. And also, it is important that we reiterate that pregnancy does not affect the long-term survival rate adversely, even if it is a hormone-sensitive.
I think that's what they're most scared of, is that if if they get pregnancies, the cancer going to get worse or recur. And that's not true. It's just that hormone positive, we want them to continue the tamoxifen for as long as possible, at least up to the 5 years. But if they're really keen to have a child, and especially with age, it's going to be harder to have a child, we can give them a break and then get back to tamoxifen. So let's just talk about a few other topics in relation to breast cancer. Could you maybe give us a few points on lactation and breast cancer and whether they can feed and how that works?
So whilst on chemotherapy, no, unfortunately, you cannot feed because there's a risk of neonatal neutropenia because of the chemotherapy. Ideally, you wait 14 days after chemotherapy so that the drug clearance is there. And yes, chemotherapy does affect the milk secretion. There was a study done by Kardonek et al. In 2010 and showed that 55% still successfully fed. So that's about half who have a problem with feeding post-chemo. And post-surgery depends. Sometime with the lumpectomy, there are major ducts which are excised, and that does affect the ability to feed.
Right.
And whilst on hormone therapy and immunotherapy, this is transmitted and secreted in the breast milk. So again, that would be a no to feeding. And sometimes post-radiotherapy, it's unlikely that they're able to breastfeed because there is a significant amount of fibrosis that is caused.
Right. So again, depending on the surgery and radiation
Correct.
is what's going to decide
Yeah.
that. Now, we had a patient we discussed on chemotherapy who got pregnant. Now, we don't want that to happen. And discussing contraception, whether hormonal is okay, not okay, what would you recommend for methods of contraception?
So there's two ways to deal with this. The patient currently has breast cancer or past breast cancer. So both ways, a non-hormonal contraception would be the best way to go. That's the safest method. If they have past breast cancer, hormonal methods are a slightly lesser risk. But if it's current, it's completely hormonal methods are contraindicated, and copper IUCD would be the safer method to use in both things. So Dr. Asha, now we've covered quite a bit. Can you tell me a little more about, the prognosis, how we would follow up, and what if there's recurrence during pregnancy? Because those are all questions that we're concerned and worried about.
Right. So prognosis is based on the stage of the presentation. There's no increased risk of, a bad prognosis or risk of recurrence just because they're pregnant. It just depends on the stage of presentation. Unfortunately, like we discussed, generally there's a delay in diagnosis. Presentation is at a later stage. And because they're younger cancers, the prognosis is poorer. But otherwise, if we pick it up at an early stage, it is a stage for stage match. Follow-up, we follow the routine method once in 6 months for the first 5 years and then yearly after that. And recurrence risk, again, not increased because of the pregnancy. It's based on the biology of the disease, triple negative and HER2 being more common, and the stage of the disease.
Okay, so that's quite reassuring. At least we can tell them that the pregnancy as such does not cause the recurrence or hinder in any way.
Exactly, yes.
Yeah. So how would we go about genetic counseling? Because, all these women come to us and obviously they have daughters, or they're worried that when they're pregnant with the baby, that could be a baby girl, and what the risk is to her because, they have breast cancer. So how would we go about that?
Right. So usually the younger women are the ones who are pregnant and getting the breast cancer. So that is an indication for genetic counseling first, followed by testing. I'm not going to go into too many details, but the genetic counseling and the testing, if positive, is going to help us in two ways. One, what is the significance for the patient? And two, what is the significance for family members? So for the patient, it does kind of help decide the choice of surgery. Also, options to discuss a risk-reducing mastectomy and a risk-reducing salpingo-oophorectomy. And the second is the implication on the family members. Now, if the patient is positive, then the family members are given counseling, and then they can decide whether they want to test or not, and further discuss risk-reducing surgeries. I think the role of PGD testing has come up majorly. Many patients want to know if it's possible to check for the BRCA gene and then take a call with IVF because they're quite keen that they don't want to pass on the gene. So I think this is coming up, developing, and going to be.
Yeah, that's right. I mean, we have a lot of us do the PGD as well. Yeah. So basically, to summarize, if you look at this chart, it gives you the whole gist of what we were talking about today. So if you see a patient in the first trimester and they come with you with a breast lump, you do the basic investigations. And if it is breast cancer, then you give her the option of termination and standard treatment. If not, surgery, chemotherapy in the second and third trimester, radiotherapy only after the delivery, and hormone therapy after. And always remember, try to stop the chemo 2 to 3 weeks prior to the delivery so that we avoid the maternal and fetal neutropenia. And they can always deliver and then go on to complete their treatment. If it is in second and third trimesters, if you see here, it depends on whether it's, which stage it's at. If it's locally advanced, then we, give them chemotherapy without surgery initially, and then delivery and then completion. And if it's not locally advanced, I guess you have the option of lumpectomy and MRM, and then chemotherapy, hormone, and radiation after the delivery. And chemotherapy, again, can be done in second and third trimesters.
And just some take-home points. I think key emphasis on the multidisciplinary team approach, careful evaluation and examination of any breast symptom during pregnancy is important. High index of suspicion is going to help us avoid a diagnostic delay. And it's not necessary that a termination has to be done. It does not improve the survival rates. So just to reiterate again, first trimester, we're looking at surgery, possibility of surgery. We're not really looking at any other treatment in the first trimester. Second trimester, chemo, surgery are both allowed, and third trimester the same. And after deliveries, we're going to look at radiation, anti-HER2 treatment, which is Herceptin, and endocrine therapy. So we have to kind of time it in such a way, and the order of chemo and surgery in such a way that we fit into that specific treatment modality in that specific trimester.
So these are our references. Thank you.
Thank you very much.
Thank you, Dr. Shravya and Dr. Asha, for the detailed blow-by-blow discussion. From the chat box, we have a lot of compliments being showered for the excellent presentation. Keep up the spirit, and we'll move on to our next talk. We'll take the questions and the expert comments after our next session. So keep the compliments and questions coming in on the chat box. Our next talk will be on gestational trophoblastic neoplasia. It's always a mystery box. And to elaborate on this hidden diagnosis, we have Dr. Sneha. Dr. Sneha is the junior consultant at CSI Kalyani General Hospital. She's a gold medalist in DGO and DNB. Dr. Jayashree Gajara Juva Foxy Orator and winner of Best Oral Presentation at the 63rd AIC OG. Over to you, Dr. Sneha.
Thank you, Dr. Bharani, for that kind
Sneha, are you talking? Sneha?
to share my screen.
Full screen. You have to make it full screen.
Sneha, ma'am.
Yeah, Sahiti, go ahead, tell us.
Ma'am, we can't hear you, ma'am. Sneha, ma'am. Ma'am, we were
The
not able
bandwidth
to
is
hear.
less. She has to switch off the video, Sahiti. Tell her maybe
Yes,
the bandwidth
yes.
is less. That time she was able to share.
Yes, ma'am.
Tell her, no?
Sneha, ma'am, am I audible? Sneha, ma'am.
Okay.
Yes, ma'am. Now it's audible, ma'am.
Hello.
Yes, ma'am.
Am I audible?
Yes, ma'am.
Really sorry.
Sneha, you have to share your screen. Sneha?
Ma'am, please share your screen, ma'am.
Sahiti?
Yes, ma'am.
You have Sneha's number. I did call her. I'll call her again. But then if you can tell her.
It's better if she logins again, ma'am. Sneha, ma'am. I think so. Her network was poor.
Am I audible?
Yes, ma'am. Ma'am, please switch off your video for some time and check whether slides are working or not. Slides are not visible, ma'am. Yes, ma'am, we can see now. Please make it full screen.
Okay. Very sorry
Yes, ma'am.
for that delay. So when it comes to GTN, we have a very clear set of guidelines. The diagnosis is very evasive and it slips through our fingers. I'd like to make my case by discussing a few real case scenarios as to how it was missed. In fact, it was not even brought to the gynec department, but it was managed by other departments. And even when it came to us, it presented in a very different way that the diagnosis was missed. So we'll go through the first case. This is a 25-year-old woman, Paravan living one, who had a full-term normal delivery 1.5 years back. She resumed her menstrual cycles 9 months at 9 months, and it was regular with normal flow. She presented with complaints of bleeding per rectum to the surgical OPD. That was her only complaints. Hence, it was evaluated by the surgeons, and she underwent colonoscopy, where multiple fleshy growths were visible in the colon, and biopsy were taken. At this point, colon CA was suspected, but everybody was a little worried because it was very unusual to see such a young woman present with colon CA. As a part of the workup, they also did imaging such as CT of abdomen and pelvis, chest X-ray, and CT brain, which showed that there were extensive metastases. At this point, the histopathology for the colonic mass came back as choriocarcinoma, and after that, the beta HCG was done, which showed that it was at a very elevated level of 1 lakh, and at this point, she was referred to gynec oncology. Now, going to another case scenario, we have a 27-year-old primee who came and delivered, had an uneventful full-term emergency LSCS for fetal distress. The postnatal period was uneventful and she was discharged on the 3rd day. 2 months later, she presented to the gynec OPD with history of heavy bleeding, continuous bleeding for more than 10 days, changing multiple pads. At this point, imaging and vaginal swab was taken, and she was evaluated for heavy menstrual bleeding, probably suspecting an infective cause or other causes of AUB. And the ultrasound showed that the ET was thick and irregular with vascularity. Retained products were considered, but again, this was unusual because she had presented after 2 months. The swab showed no growth. At this point, DNC was done, but histopathology was not sent. She was sent home. She continued to have spotting PV for more than 6 months, which we had found out retrospectively because she had not come to us for follow-up following that. At 8 months postnatal duration, she came to the medical OP because she had severe intractable headache episodes, and this was managed symptomatically with painkillers at that point. Few days later, she presented to casualty with seizures. Because it was a neurological symptom, a neurologic consult was obtained. Brain CT was done, which showed a space-occupying lesion, and she was immediately planned for surgery. No further evaluation was done. Intra-op, it was found to be a highly vascular lesion, and there was intractable bleeding, and since this was unexpected, the patient arrested on table and we were not able to save her. The biopsy that was sent had come back as choriocarcinoma. Now that we have gone through the two case scenarios, I would like to quickly go through the basics of GTM. GTM comes under a spectrum of disease called as gestational trophoblastic disease, which has benign on one spectrum and malignant on the other end. The benign includes complete and partial mole, and malignant can be non-metastatic or metastatic, as we all know. And here, what I would like to highlight is mostly on choriocarcinoma, because it has very good prognosis of cure once it is diagnosed, and if the patient follows through the chemotherapy regimen and follow up. It is one of the cancers that has very good prognosis and survival rate following treatment. And that's what makes it very important that we pick up this disease at the right time. Now, where does the cancer arise from? To put it in very, very simple terms, it's the cancer of placenta, which arises from the trophoblastic cells. So for the trophoblastic cells to be there in the uterus, she must have been pregnant previously. The most common scenario that we see is the GTM arising after a molar pregnancy. But this is not the case always, because this can happen after live birth, miscarriages, or even an ectopic pregnancy. So please remember that this can happen after any kind of pregnancy event. Now, when you are suspecting GTM, the approach is that first we diagnose and then stage and score the disease, followed by treatment and then the post-treatment survivals. The problem lies in the diagnosis part. Now, they can present with a variety of symptoms, but not always do we suspect GTM. When it is a localized disease in the uterus, it can present with some abnormal uterine bleeding type of pattern, like intermenstrual bleeding, abnormal bleeding following more than 6 months after pregnancy, or it can even be asymptomatic. When a patient presents with such symptoms to our OPD, the common things that come to our mind is usually any AUB. We usually think in terms of palm coin, or could it be PID or RPOC? But GTM is not something that comes immediately to our mind. If the disease is already metastasized, it makes the diagnosis even more difficult, because they might not come to us as the primary physician. They can present with cough or hemoptysis if it has metastasized to the chest, focal neurological deficits, then they will go to the neuro, or they can even have epigastric pain, in which cases we start thinking is it URI, tumor, gastritis, or cholecystitis, or any other such localized cause. Now, coming to the examination, if it's a localized disease, we might note sometimes that there might be uterine subinvolution or asymmetric enlargement. We might think of endometritis or RPOC again. If it is metastasized, one of the pathognomic features is suburethral nodule, but this is very rare to find. In investigation in localized disease, imaging of the uterus such as ultrasound, CT, or MRI might show some highly vascular, irregular foci of growth, but this is very non-specific. There might be associated thecal lutein cysts because of the increased beta-HCG level, and there will be highly elevated beta-HCG. But the problem here is that we can detect only if we order the beta-HCG. If we do not have the suspicion, we will not order this test. If it is metastasized, there can be snowstorm or cannonball lesions on the chest X-ray. So the diagnosis is made by the FIGO criteria. The first criteria is by sending histopathology from the lesion, if at all we have a lesion. The second is by following up serum beta-HCG in a particular way. The first is serum beta-HCG measured over 3 weeks, 4 samples, and if there's a plateau over these 4 samples, or if serum beta-HCG is done over 2 weeks with 3 samples, and if there is a raise, or if there is persistently high beta HCG for 6 months. Even though it looks like a very clear-cut criteria for diagnosis, there are some pitfalls. When it comes to histopathology, we might not have a tissue available for histopathology and it is highly vascular. When it comes to serum beta HCG follow-up, if it is a follow-up following molar pregnancy, yes, we would do this beta HCG follow-up very diligently. But what if the patient presents after other pregnancy events, especially if she presents years after a pregnancy event, which can even be a situation. So this is where the difficulty lies. Now coming back to our case. The first case, we can see that she's been managed properly. She was referred to the gynae onc at appropriate time. She was diagnosed to have choriocarcinoma stage 4/10. She received imacocycles. She was on proper 2-year follow-up with no recurrence, and she went on to have another uneventful pregnancy. But the second case, where we lost the patient, in this case, we could see that at so many times, or so many parts where she had presented, we could have intervened. First, when she came at 2 months of postnatal with heavy bleeding, we could have suspected, could it be GTN? Second, when she had a DNC, it was very important that the HPE could have been sent. We could have made a diagnosis at this point. If we had told her the red flag signs after the symptom after the DNC, such as if she continued to have spotting for more than 3 weeks or heavy bleeding, maybe we could have picked up or suspected at that point. The last, when she came with seizures, only the focal cause was suspected and better evaluation could have been done to see if there's any other organ involvement so that choriocarcinoma could be thought in a corner of our mind. So my take-home message is this. If you encounter any AUB following pregnancy event, irrespective of the type of pregnancy or duration after pregnancy, please always remember, or please think, even though it is very rare, just have it in the corner of the mind. Can it be GTM? If so, simple tests like urine pregnancy test can be done, followed by serum beta HCG and imaging to do the further metastatic workup. A test in time can save lives. Thank you so much for your patient listening.
Thank you so much, Dr. Sneha. GTN is truly a mischievous masquerade, I think. That brings us to the end of the third session. May I request our experts, Dr. Shanti Ganesing ma'am and Dr. Ramanand sir, to take over now and share their clinical expertise on these cancers. Maybe we'll begin with Shanti ma'am.
Good evening. I thank Dr. Rajshri for having given me this opportunity to take part in this wonderful symposium. And as nicely, the talk by Rajshri was very, complete. And so the main thing is when patient complains of bleeding in pregnancy on and off repeated episodes, we should not think it is only threatened miscarriage. We have to put in a speculum and see. So that is the most important thing. And in 90s, when I was an assistant in IOG, we used to do routinely, early 90s, we used to do routinely pap smear for pregnant women. After that, it went out of vogue. And you have nicely reiterated about the colposcopy being safe during pregnancy. And we understand that MRI probably would be the investigation of choice, and chest X-ray can be done. And size of the lesion and gestational age matter a lot for the prognosis. So the cutoff of 22 weeks matters a great deal, which will decide on the mode of management. So it was a good job done by Dr. Rajshri. Then we had the, interesting dialogue by Shravya and Dr. Asha Reddy. And we should understand that here also a good clinical examination of the breast in the first visit, antenatal visit, is very, very important, because pregnancy associated, the peak incidence of pregnancy associated breast cancer is 32 to 38 years. Many of nowadays, quite a few of them fall into this category. So it's very important for us to be very methodical, and they had really nicely stressed about the various aspects in a very interesting way. And lactation is very important, even from the affected breast, where operated the breast, it can be done, although difficulties can be there. And counseling is a sheet anchor in all pregnancies with malignancies. And so that was well brought about. And so we should understand the instances 1 in 3,000 means it is not too rare. And the talk by Sneha was excellent, nicely bringing out various points. And actually, gestational trophoblastic neoplasia is indeed sometimes you should have a high index of suspicion. We have seen cases just presenting with fits and admitted in medical ward who don't give history of any hydatid mole or any pregnancy even from time. But then we should understand that we should have a high index of suspicion. We had seen quite a few cases of suburethral nodules. So important to put in a speculum and see. So that is very, very important. And it is a curable cancer that we should always think. And when we were students in Madurai, we used to see a lot of hydatid mole, but then we have evacuated 36 weeks mole and all these things. But now we understand that with the advent of good ultrasound, early diagnosis and invasive moles also can be identified very early and treated appropriately. So hysterectomy is not the answer for everything. And the WHO scoring system, which has been taken up by FIGO, that really helps us to a certain extent to decide about treatment. So well done, all 4 of you. Thank you.
Thank you, ma'am. Over to you, Ramanan sir, for your comments.
Thank you. Namaskaram to all. Actually, it was a learning for me. Personally, my own experiences or in pregnancy and cancer would be less. But the choriocarcinoma thing, very important point. It is axiomatic for any medical oncologist. If he sees a lady who could be in the age group to fit into pregnancy, any lung lesion or any brain lesion, we need to always keep choriocarcinoma in mind. So that is axiomatic for us. So that is an important point from my end. And the dialogue on that breast cancer was very interesting. A lot of good learning for me. But one personal thoughts will come into this. Like most of us would have been trained by our seniors. So whenever such a scenario, we were facing it in our early part of our career, the only answer we used to get is termination. So moment our chief used to say, okay, pregnancy, first thing he will say, terminate, go send her, and then call her back. So our own personal biases are going to play. So it would be keen to know from both our speakers, from Asha and from Shravya, that if they are going to encounter this scenario, personally, what would they say? The first trimester case, would they say the lady with that breast cancer who has come in, it's a difficult thing. Whether what will happen is most times the doctor's personal biases will also come into play. So that is important. And after treatment, in the second year or third year, when the lady asks whether can I get pregnant or not, that is also a very important ethical questions will come in. And there too, the doctor's bias will come into play. Would we be comfortable to support the lady's decision to stop tamoxifen and then have her pregnancy? Many a times in practice, we would immediately said, don't do, continue tamoxifen. As medical oncologists, we will be giving them, don't get pregnant, just continue the tablets. But I think we need to change, and we need to definitely keep what the patient wants in our mind. And if the patient is keen, we have to help her by telling, yes, this is possible after a shared decision making. These would be my thoughts. And Madam Rajshree's talk was very good and good learning for me. I have actually no experience in cervix cancer and pregnancy.
Thank you, sir. There are more compliments from the chat box to the presenters. And since we're running a bit late, I think we'll move on to the panel discussion. There are a couple of questions. Maybe we'll take it in the end after the panel discussion. The next is a much awaited panel on adnexal masses in pregnancy. I welcome our moderator, Dr. Jayashree Gajraj ma'am. She's Senior Consultant in Apollo Specialty Hospital, MGM Healthcare, Mangai Women's Health Exclusive. She's past President of OMSI, past Chair AICC-RTOG South Zone, and Founder Secretary, Chennai Menopause Society, and its past President too. In conversation with her, we have an elite list of panelists. Dr. Vijaya, Professor at Sri Balaji Medical College and Hospital, former Director IOG, Vice President OPSI. She's a national level master trainer in obstetric skills, cervical screening and colposcopy, a UG-PG examiner, and I think every student's favorite teacher. I take some authority in saying that. Dr. Umara ma'am, Director and Consultant, Sitapati Hospital, founding member, ATNRC OG. She's actively involved in many teaching programs and workshops, and she's the coordinator for MRCOG aspirants since 2003. Recipient of Women Achievers Award from Rotary International in 2015 and International Diabetic Federation's Blue Ring Award in 2012. Dr. Shruti, she's a consultant gynae oncologist and robotic surgeon from Asunda Shaw Cancer Center, Bangalore. She's a member of Association of Gynecological Oncologists of India and European Society of Gynae Oncologists. Dr. Ramanan sir, consultant senior medical oncologist. He was also our expert. Welcome back, sir. Dr. Purnima, she's a radiologist who's qualified from Bernard Institute of Radiology, Madras Medical College. She worked with Precision Diagnostics and has founded Athena Diagnostics. Over to you, ma'am.
Thank you very much, Varni. I welcome all the delegates and my panelists as well as I share screen. I think from what we have been following up till now, it's obvious that the experience on malignancy and pregnancy is limited all round, at least it seems so. But let's see how best we can try and bring out some of the common problems that we encounter. Adnexal masses, as we all know, is we do see an adnexal mass, but it doesn't necessarily have to be a malignancy. I think Dr. Uma and Dr. Vijaya will agree with me about that. It's not uncommon to see it, but how often do we see a malignancy? If it is a malignancy, how are we going to diagnose this? How are we going to manage? Will be the agenda for the panel today. I must apologize that it would be actually a dry panel because I was not able to put in enough pictures. I couldn't get enough pictures, and a little bit of a flu today also was a setback for me. So just go on to, yeah, I think, are we okay? We can see. So actually they're not commonly encountered and they're rarely malignant. Very often these masses, as we follow them, either resolve spontaneously or we know that we manage them conservatively during the pregnancy. The tumor markers, if we are going to rely on them for diagnosis, each and every obstetrician knows that it is not reliable because the levels of tumor markers itself can be affected. And several diagnostic modalities are there. The tool that we have in our hand and the tool that we use during the pregnancy itself is ultrasound scanning, and Dr. Purnima is going to throw a lot of light on the use of ultrasound for these adnexal masses. Differential diagnosis, of course, includes both benign and malignant, and years of experience teach us that we cannot ignore and say this is highly unlikely to be malignant. We need to keep it in mind. And management, without doubt, has been and will continue to be a subject of debate. There is no consensus and we don't have any very large series to rely on. And to some extent, maybe tumor size, site, the trimester when the mass was detected, etc., would probably play some role. So to begin with, let me ask Dr. Vijaya and Dr. Uma, how many women have you seen with adnexal mass, say, the last 3 years?
Hi, everyone. Good evening, Jayashree ma'am. Am I audible?
Yes, Vijaya, go ahead.
Yeah. Thanks a lot, Jairani and Rashri, for this wonderful topic. And this is the take-home message has already been said by Jayashree because it is so confusing during pregnancy. And to be very frank, we have seen unilateral cyst benign most of the time in pregnancy. The malignant and bilateral very rare. Maybe I can say less than 1% in IOG itself.
So, Uma, what has your experience been in this?
I think so. Maybe 3 or 4 in a year, I would say, where there's significant adnexal masses. Not talking about the corpus luteal cysts and simple follicular cysts. Most of them turn out to be either endometriomas or dermoids and are essentially benign. In the last 3 years, I think I've had 2 women where a suspicion of a malignancy was raised, but it thankfully turned out to be a benign cyst. So, yeah, indeed, it is not common.
Right. So, Shruti, how many cases of malignant adnexal mass have you had referred to you, say, in the last 2-3 years? Dr. Shruti?
Can you hear me, ma'am?
Yeah.
So recently, 6 months back, we had a case, but unfortunately, she was a known case of immature teratoma, operated in 2017. And after that, she was given chemotherapy. And after 5 years of disease-free interval, she became pregnant. And in her 9-week scan, there was a cystic mass, multi-cysted mass in the pelvis and in the left adnexa. So we offered her MRI, and MRI also showed a mass, cystic mass, but they mentioned that it could be recurrent or residual disease. So we had one case, but which turned out to be mature teratoma. I mean, after pregnancy, maybe I'll let you know about the case later. Yeah.
Okay, Dr. Ramanan, what has been your experience?
In the last few years, I had one lady referred during pregnancy, just after pregnancy, and she had a borderline tumor. We said follow up. I didn't see her during pregnancy at all. And then another lady with colon cancer with pregnancy. But last few years, no, except these 2 patients.
Okay, so if we were to look at literature and from our own experience, would you say primary is more common than secondary in the ovary?
For me, primary.
Right, and if what would be the commoner pathology? Epithelial or a germ cell tumor or a sex?
Even though the age generally says that it should be germ cell, but commonly the literature says that it could be still epithelial and borderline tumor. But obviously, young person, so I'll also keep germ cell in view, a borderline tumor, even a stromal tumor.
Right, Shruti, would you agree with this?
Yes. Most of the cases, what we have gone through is epithelial cancer, but yeah.
So Uma and Vijay, I think will agree that very often it's an incidental finding during routine pregnancy intervention, and therefore, per se, a significant adnexal mass detection is not going to be very common. Ultrasound has certainly made a big impact on this, and we are talking of an incidence of anything ranging from 1 per 76 to 1 per 2,300, and this just shows that the reporting, the documentation, the cognition of whether something is malignant, not malignant, how important it is, I think, is still on. I don't think we are recording enough. Maybe we should start recording and documenting more of these masses and the characterization, so we are able to then slot and say what it is. So that's something for Oxy to take up, I think. We'll move on to the first scenario. 25-year-old primate comes to you for opinion, Dr. Vijay and Dr. Uma. you do an dating ultrasound. It just says, I mean, this has been done outside. SLIUG 8 weeks. Complex large right adnexal mass 6.5 into 7.2. Residual reaction good. I'm sure both of you agree that this is a very common reporting for the ultrasound. Purnima may disagree with me, but this is how we see it. Uma, how will you take this forward?
So first I will
done outside.
Yeah, first I will look to see if there are images given with the report and whether that was a transabdominal or a transvaginal scan. Clearly, this impression is incomplete. They're just stating the facts. They're not giving any interpretation. So if we have an image, I like to look at it to see whether there's anything there. And in any case, and one other thing that I would ask the young lady is whether she has a scan from before her pregnancy at any point in time to see if there is this mass documented somewhere. It may not be there, but it's worth asking for. And probably, if I'm not happy with the images, then do an ultrasound or refer for an ultrasound where the adnexal mass is reported as per IOTA guidelines with an indication of whether there are benign or malignant features and to tell us what kind of mass we're looking at.
So Vijaya, I think that would probably be your thought process also.
But I think the imaging and pregnancy is very, very confusing. Even a corpus luteum with a little hemorrhage or an endometrioma, we might mimic like a solid or papillary projection. As Uma said, a good ultrasound is definitely needed, and still we are confused. And if the patient is asymptomatic, we have to repeat it again, a good ultrasound. I don't think MRI is needed at the moment.
So Purnima, for a good ultrasound, they are referring the patient to you. How would you report this? I mean, you're repeating the scan. What are the features you will look for to give them a better picture rather than two adjectives which say complex and large?
Yes, ma'am. Dr. Uma said it all. Uma ma'am said it all. So a complex or simple cyst is not the way an adnexal lesion should be reported at all. I would rather say how big the cyst is, whether it is thin-walled or thick-walled, does it have any solid components inside it, whether it has any septations inside it, what is the characteristic of the papillary projections that is there any vascularity in the solid areas, if at all it is present, and what is the type of papillary projections that is seen. All this needs to be told. In other words, it is the IOTA classification to see if it either fits into all benign category or malignant category, or it is a combined thing. So we can always give a report based upon the IOTA classification.
Yeah, we'll come to that in a while. We'll come to the details in a while. So you would certainly repeat the scan and you would give her more details.
Yes, do a abdominal scan, preliminary abdominal scan, then follow it up with a vaginal scan to look for more details and then give a detailed report.
Okay, so from the repeat scan, predominantly it says that it's a predominantly clear cyst with some debris in it. And so now, Uma and Vijay, what will your advice be?
I think we can reassure the patient and as well as the relatives, and we can go and follow the patient with the repeat scan. I don't think any active intervention is needed at the moment. Maybe it will disappear after the first trimester.
Okay, so one of the family members known to you, Shruti, they come to you asking for your opinion. Sorry, Uma, you want to say something before that?
I just want to say that at 8 weeks with a 7-centimeter clear cyst, the only other thing I would add to what Vijaya said is warn the woman and her family that if she should have any acute pain to come in, because the only risk with a clear cyst early in pregnancy is it can tort, and therefore that information they need to have. And then we just have to follow up.
So Shruti, if at this stage somebody came to you because they know you are a gynae oncologist, they want your opinion, what is your advice going to be? Uma and Vijay have said that there's no problem, we can continue the pregnancy.
So basically it seems to be a more pointing more towards benign cyst. So what I will ask them is, I'll ask them to come in the second trimester and see if it is persistent. And if it is persistent, then again do a ultrasound and features. If there is any malignant features arising, then we can proceed with surgery, or else we can just keep monitoring.
So, and continue to monitor would be by an ultrasound scan. And would you subject this to Doppler, Purnima?
Definitely, ma'am. In the first instance itself, see for any solid areas and look for any vascularity, abnormal vascularity within the septations, if at all it is there, or within the solid areas it is there. We definitely have to document about the vascularity of the lesion.
Okay, now we are following up this lady, a size that was given in this particular case, after 26 weeks, 28 weeks. How well will you be able to follow this up?
Beyond 20 weeks, if at all there is an increase in size of the cyst, it will be difficult to be seen by ultrasound. It's not amenable vaginally, and abdominally also, because of the gravid uterus, sometimes we might not be able to see the cyst clearly. In that case, if we need to have to evaluate the cyst thoroughly, we can definitely ask for an MRI pelvis at that time.
Right. So you've told us some of the features which will point towards a malignant mass. And is there an ideal scan frequency, or normally as obstetricians, we would probably do a first trimester anomaly growth scan? Is that sufficient, or would you want to follow it up more frequently?
As such, there is no protocol to say that we need to follow this cyst in this interval. There is no set protocol like that. Along with the regular obstetric scan, we can follow up. And as Uma ma'am said, if at all the patient develops any symptoms of acute pain, it's because of torsion or acute hemorrhage into the cyst, to evaluate. In that case, then she needs to come for the scan, irrespective of when the previous scan was done. So if at all there is any emergency, then they need to report. Otherwise, along with the regular obstetric scans, the cysts can be followed up.
So would you advise then that after 28 weeks, they should go for an MRI to follow up that cyst?
If at all the patient is symptomatic, ma'am, because in our clinic, we have seen cysts of 10 centimeters, 12 centimeters, where you'll be able to see them through an ultrasound. Then we have never asked for an MRI, or we have never suggested for an MRI. We follow it up till the patient has delivered. They come postpartum also with a cyst, and we follow them up that way. Unless there is malignant features that you've seen in the first trimester and you want to follow it up, and because of the gravid uterus and other things, you're not able to see the cyst properly, then an MRI can be asked. Otherwise, MRI is not necessary in a routine way.
So you're not, even at advanced gestation, if you're not able to see, there is no need for a MRI.
Yeah, if the patient is not symptomatic because of the adnexal cyst, then we need not have to do an MRI.
Okay, fine. So these are some of the features, I think, which you brought out. You said the diameter, the gross internal septa thickness, whether vascularity is present, etc., papillary projections. And I think all this, when you will combine and give us a report, which can be reassuring. So we are able to classify them or categorize them as high risk, intermediate risk, or low risk. Is that correct?
Yes, ma'am. This is by the pattern recognition, we can say whether it is high risk or intermediate or low risk, we can say. To be more precise, we can use the International Ovarian Tumor Analysis method, IOTA, where you have a calculator system which you can download it in the Google. You can apply fill in the details that they ask for, and you can get percentage wise what is the risk factor that this patient has, whether it is a benign lesion or it comes in the borderline category or it is a malignant lesion. This IOTA classification is very, very useful.
Okay, Dr. Uma and Dr. Vijaya, what about RMI? Is this a risk of malignancy index? Is that applicable in pregnancy? So that's what we use normally, don't we?
I don't think we can use RMI in pregnancy. It's more applicable in the perimenopausal and age groups, is my understanding. I mean, you can correct me if I'm wrong.
It's not applicable.
IOTA, I think you can apply in pregnancy as well. Because it basically tells you, gives you the features, and as Purnima said you could do pattern recognition or you could use their score. There was a question in the chat box about tumor markers, and none of us have asked for tumor markers in this case. I think because it's a
coming
clear
up.
cyst. No,
It's coming up.
in this case, because it's a clear cyst and we are not really thinking of a malignancy, we don't routinely ask for a CA-125. I don't know if Ramanan feels differently, but none of us would have asked for it, I think.
No, we are soon going to be referred a complicated case very soon. So in that, we will bring it up. Ramanan, your comment on this clinical stroke, way of suspecting a malignant mass. Is there any comment on that? Leave alone RMI, is there anything else?
No, I think I'll be happy if she doesn't come to me. But this clear cyst lady, I will also say follow up, come after 3 months.
Right, okay. And Purnima, one quick word. You spoke to us all the features, etc. So is this something that you are seeing more often now in pregnancy? Can you give us a few lines on this? Is this benign or malignant?
Yes, ma'am. As a beginner, when I have seen this, looking at the cyst, it's a thick wall cyst with low-level echoes. You see a septation and say irregular papillary wall thickening is overseen. But the most clinching point here is this papillary projection that we see within the cyst, which is well-defined, rounded, and hyperechoic. This is so pathognomic of desudalization of an endometriotic cyst. For a beginner, this can be like a solid area. Sometimes we see vascularity within these nodules also, which gives a high suspicion of malignancy. But this well-rounded hyperechoic nodules within the cyst is so pathognomic of desudalization. So if we are aware of this, then we will not confuse that it is a malignant mass. So
yes, I think, are you seeing this increasingly now, or are they recognizing it more often now?
Maybe because we know this, we are recognizing more of this is what I think. Earlier also, when I had started, I would have given it as a complex mass or a mass with a solid nodule, a query malignancy and all this. Now that we know to recognize these patterns, we are more confident to say that this is a desudalization. And as you said, yes, we are seeing more of these cases nowadays.
Okay, so I've just thrown this in more to say that we have to be aware of this. How many times have you had the occasion to refer a patient for an MRI?
For desudalization, we have not referred till now. We have not referred anyone, because when we see this, we definitely go and ask for the history. As Uma ma'am said, we would like to know whether this patient earlier was treated for endometriosis at any point of time. Did she have an endometriotic cyst? All this history taking gives us the reassurance that yes, we are dealing only with desudalization and we can just follow up with this patient. So till now, we have not asked for MRI for a lesion like this in our ultrasound study.
Okay, so, and Shruti, you would have been referred, like you would be the next level of referral, isn't it? So have you had occasion to refer for an MRI at any point?
We kind of, one case which was mentioned as complex mass, we got an MRI done. It was around, I think, some 12-week pregnant lady. An MRI clearly showed it was an endometriotic cyst. So then we just followed up.
Okay. Dr. Ramanan, your comment on this?
Whom I will send for MRI?
Yeah.
No, obviously, if it is a suspicious cyst is there and we are not sure, we want more clarity, definitely we will ask. We won't go only with ultrasound. Moment the sonologist says there is something suspicious plus minus, obviously the next investigation is to rule out malignancy. If they come to me, we have to rule out malignancy. And hence, I would ask for an MRI.
So this comes to much awaited tumor markers. Both Dr. Shruti and Dr. Ramanan, your comment on this. How useful or reliable are tumor markers in pregnancy? Go ahead, anyone. Shruti, you want to go ahead? Yeah.
So basically, we know that CA-125 is sometimes raised in the first trimester, the last trimester, and also postpartum. So in spite of that, we can get one baseline, if there are any suspicious features, we can get one baseline level done, because if it is too raised, as of now, the data shows that in normal pregnancy, the highest CA125 reported is around 1,500 something. But if it is more than that, it might point towards malignancy. So it's not going to help us. We're not going to decide any treatment modality based on the levels. Also, in yolk sac tumors, the alpha fetoprotein, if it is more than 10,000, or in malignancies, in pregnancy, we see it as multiples of median. So if it's more than 9, it might point towards malignancy. So a baseline tumor marker, specific tumor marker can be done. But we're not going to decide anything based on.
So it's not reliable, but you may still want request it. Dr. Ramanan, please.
Reflexively, they will get done up. If you're going to suspect malignancy and a young lady, then all that report will come, then we all will get confused, and whatever Shruti said will happen. We are not going to make a decision based on that, but possibly it may get done up. Very, very high levels will be suggested.
So,
make a comment, sir. What about HE4 and that are all much more specific than CA125? In certain studies, they have said like that, AMH and HE4 and inhibin. Your comment, sir?
Yeah, they have been reported in the books, but I would have never asked because I hardly see a patient like this. So my personal experience in asking these tests would be next to zero. But what you said is very correct, madam, that the names which you mentioned, they are much more specific in a pregnant situation. They may not be elevated because of the pregnancy or because of the fetus.
And that is very specific for granulosa cell tumors. So apart from that, which is not very common in pregnancy.
So a negative doesn't really mean anything.
Yeah.
It need not mean anything. Am I right?
Correct.
Okay. So then we go on to this second scenario where we have a 30-year-old primipara, 7+ weeks, heterogeneous lesion right at nexa, fat-like echoes with hair stranding. They reported it as a dermoid. Purnima, your comment on this before we ask for advice. Is that the correct way of reporting a dermoid or?
Fat, hair strands, I don't know whether we'll be able to differentiate in an ultrasound.
First time I have seen this report, that's why I'm asking you. I've never seen this.
We have never seen hair strands in a dermoid. Dermoid has a typical look in ultrasound, which we cannot miss. We see fat components can be there, or it is a hyperechoic mass that is there. So when we see a dermoid, we directly report it as dermoid and look for the vascularity. If there is any abnormal vascularity, then we might think whether it could be something, some form of teratoma or something. Otherwise, a dermoid is completely avascular, and directly report it as a dermoid rather than saying hair strands or fat-like echoes.
So Vijaya, how would you want to manage this patient?
Dermoid cyst, I think more chances of undergoing torsion in pregnancy. And if you're sure of a dermoid, laparoscopic removal, cystectomy. But then I think you can wait for, maybe if she's asymptomatic, you can just follow her up, wait till the first trimester is over, and then you can do it at 14 weeks.
So, Uma?
But then there are studies, they say even in the first and third trimester, it's not, harmful, even this laparoscopy.
Right. Uma, what is your comment on this? Would you want to take her up for surgery or wait and watch?
If the scan suggests that it's a benign, it's a dermoid, there aren't any concerning features flagged, I would just wait and watch unless she becomes symptomatic.
Right.
Yes, you can go in and operate on a dermoid, but I don't know if we need to do it unless she presents with pain or there's something that happens when we follow up, size increases, vascularity develops, something flags a concern, then I would go in. Otherwise, we'd just wait and watch. And for these women, after the first trimester, actually postpartum is when they're also more at risk for torsion. So that's also when we need to ask them to be careful.
Okay, so I'm currently sitting on her. She had her anomaly scan last week. She continues to be asymptomatic.
Yeah, I would sit on her too.
So the same scenario, if Purnima says, highly suspicious of malignancy, she's reviewed the scan and she says highly suspicious, would either of you or both of you refer her to Dr. Shruti at this stage?
Yes, certainly. I think if there's a high suspicion of cancer in a lady who is pregnant, getting an onco opinion is certainly valid to plan management.
Yeah, should be a multidisciplinary approach.
Okay, that brings us to the next question. Traditionally, all of us have been told that pathology is the ultimate, pathology is the, so many things. So, Shruti, is there a role for cytology or biopsy in this patient?
For this particular patient, which is unilateral, which is it is intact, there is no ascites, we can actually, and especially they have said it's highly suspicious of a malignancy, we can actually go ahead, do a laparoscopy, take the unilateral ovary can be removed and sent for frozen section. And based on the report, then we can proceed further.
Yeah. So what is the feedback you will give to Dr. Vijay? I mean, you want the pregnancy to be terminated, or you will just do the oophorectomy and she can allow the pregnancy to continue?
We can actually, there will be a tumor board meeting in detail, and then we can take the concerns of the patient also and the obstetrician, and then there is no need to terminate the pregnancy. We can, if the patient wants to continue, she can continue the pregnancy.
Okay, so cytology will not give any information. Is that right?
When we do the laparoscopy, we can take the cytology also for staging purposes.
Okay. And what about like a guided biopsy earlier? There is no need.
For this particular patient, we are not going to do it because it's an intact mass. The whole specimen, it will unnecessarily upstage the disease. So it's better to take the thing intact, put it in the endo bag, and send it for frozen section.
Dr. Ramanan, any comment on this?
No, madam. I think we will definitely interfere surgically, and this termination part question will definitely come in, because it all depends who is there in the tumor board. Senior people may push for termination because the report can come as a yolk sac tumor or a high-grade malignancy which will need chemotherapy, and she's still in the first trimester. And then somebody will say we have to give chemotherapy immediately. So it will be a complex point now.
Right.
It all depends upon the pathology. Pathology comes, I cannot have tumor board at that time because they will give in 30 minutes. I'll be operating, you will be operating, I'll be sitting somewhere else. Difficult question now. Because it comes as a germ cell tumor. If it comes as a borderline tumor, everybody knows what is to be done.
What should be done if it's a borderline?
Yeah, we all know that there's no chemotherapy. So I am clear that I'm not going to be involved. But if it comes as a yolk sac tumor, even if it is stage 1, there'll be a discussion that we should deliver treatment now within 6 days, within 7 days, as soon as the wound heals. All those things will come into play. So this termination thing will come into question depending upon the pathology.
So
yeah,
please go ahead. Go ahead.
If something else also comes out during surgery, that's more higher than a stage 1 disease, definitely a question of chemotherapy will come. And if you are going to deliver chemotherapy, the question will come whether we should terminate the pregnancy or not.
But if it is a second or third trimester, it doesn't matter, no, sir. The chemotherapy can be given.
No, we are
not discussing that.
7 week
we are discussing 7 weeks now. So that is the scenario.
So would a good compromise be, as Shruti said, go for laparoscopy, do a oophorectomy, get the pathology, then you counsel the patient earlier. If medical termination is required, we can go ahead with it and then go ahead with chemo if there is a malignancy. Or if all well, then we allow the pregnancy to continue. Would that be okay? Will the panel agree on that?
Yes, sir.
So if when we are waiting for the frozen section, once we get the report, if it turns out to be malignant, we can actually do this complete staging at that time only, and then after the surgery we can discuss with the patient, because there as Dr. Vijaya ma'am said, there are evidence shown that in second trimester and third trimester the chemotherapy drugs can be administered to the patient. So if the patient really wants to go ahead and continue the pregnancy, she can be safely offered chemotherapy in the second trimester. So anyway, after the surgery, I mean, few weeks after the surgery only we'll be starting the chemotherapy. So by that time, she would have already entered trimester. So if the patient is particular in continuing the pregnancy, she can be offered chemotherapy.
So, yeah. So in other words, you're saying a frozen section is essential.
And staging,
Yes.
yeah, on the same setting.
So is staging any different in pregnancy compared to the non-pregnant?
If we are suspecting early stage disease, that means, I mean, if it is stage 1A, and if we have proven that it is stage 1A, we can actually avoid chemotherapy. In that case, we should be very clear about the staging. So that time, we need to do a meticulous staging surgery. We also need to go ahead and do paraiotic node sampling, retroperitoneal node sampling, to be sure that it is early stage disease. If it is anything other than stage 1 disease, we can do a simple staging procedure. There's no need to go ahead and do extensive staging, because anyway she'll be needing chemotherapy. And if we are doing the giving chemotherapy, we can wait, and if there is any recurrence, we can do a secondary surgery instead of going ahead in the first setting to do an extensive surgery and put her in morbidity with the pregnancy.
And your choice of surgical modality would be laparoscopy.
Early stage, it will be laparoscopy.
Early stage, yeah, okay. Fine. So as we are all discussing all this, one of the family members runs off to Dr. Ramanan and says, we want your opinion, because maybe if you give chemotherapy, there's no need for termination of the pregnancy. We have discussed part of this, but Dr. Ramanan, what is your, how will you counsel?
Basically, I will definitely try to tell that if it is in the first trimester, it would be better to avoid chemotherapy. But we all know that even many years back, we are given chemotherapy even in first trimester. And there is support from various anecdotal cases from the literature that people have given in first trimester, nothing has happened, something has happened. And we also saw that 2021, the update, at less than 14 weeks, some 20-23% had some congenital abnormality. But that means 70-80 have not had it also. So after detailed discussion, counseling, if they insist, we may still continue the pregnancy. But most people, and if they are above, if the tumor board, a lot of people are there above 50-55. And if you have to give chemotherapy, they will say terminate. If it is in the first trimester, all this discussion is 6 weeks, 7 weeks. We are not discussing beyond that. But like what our oncologist said, the surgical oncologist said that, you do surgery and then she's going to recover another 6-7 weeks, and then we can give. Well, that is there. That point definitely is acceptable.
Okay, I think, Dr. Ramanan, I think we need to redefine this so-called older physicians or older clinicians. Okay.
In the sense of all of us got trained by people who would have, a lot is very much what happens in our mind. Our bias only comes onto the patient. Tell me which patient has the capacity to decide. We cannot decide whether she needs termination, doesn't need termination, chemotherapy, no chemotherapy. Most of the decisions are very complex.
Yeah.
So it is whatever we want to do, we will influence the patient in that way. That's our nature. We can't escape that bias. So what will happen is we have to change as physicians, as we see more and more, we read more literature, we have our own personal experiences, and we incorporate patients' wishes and definitely see to continue pregnancy. That's what my personal take nowadays is, to continue pregnancy. But there will be a couple of people within the first trimester, if chemotherapy is going to be given, there could be a strong move for termination.
Yeah, I think this first trimester is particularly pertinent with regard to adnexal masses, because we are going to diagnose most of them in the first trimester. So it's not like we're going to suddenly see a malignant ovarian at 28 weeks or 30 weeks. So we need to focus on the first trimester. And as you quite rightly say, there is a major mental block. Probably we need to create more awareness amongst our own colleagues first before we go ahead and talk about what is latest or what is being recommended. So we, I think, have come up on this topic quite often during the conversation about chemotherapy during pregnancy. And if suppose Shruti has done the surgery, it has come back as malignant, role for adjuvant now or later, what factors would help you and Shruti decide?
That depends upon the pathology. Obviously, if it's a germ cell tumor and anything other than stage 1 dysgerminoma or a grade 1, grade 2 immature teratoma, rest all of them will need chemotherapy. So I would be keen to start chemotherapy for any germ cell tumor at the earliest after surgery. And anyone who has a high-grade epithelial carcinoma, which is beyond stage 1A, and Shruti has done a good staging laparoscopically. So anything which is beyond 1A, I would definitely want to give chemotherapy. And if she crosses to second trimester, like everyone here understands, we are comfortable in giving chemotherapy. Obviously, working closely with the obstetrician, explaining to the mother whatever problems can happen sometimes. Definitely, we would give. But if it's a granulosa cell tumor, early stage, or if it's a borderline tumor, any stage, we would only follow it up.
So this kind of delay or procrastination, as it were, in the management, does it affect the survival rates? Is there any effect on your survival rate?
Well, anything beyond 3 months, if I wait, generally we are supposed to not give adjuvant chemotherapy. For any reason, if 3 months are over, we generally say not much of benefit. But I'm sure we don't have to wait 3 months. If it is even 7th week or 8th week, within no time we'll be in 14th week. Little delay, I think, could be acceptable unless it's really advanced and it's a germ cell tumor where wildfire spreading will be there. Then I think we will initiate as quickly as possible.
Okay, this point that you brought up about after 3 months adjuvant treatment is not advised. Can you elaborate a little more? Can you tell us a little more about it?
Yeah.
Why?
Generally, in any adjuvant treatment, madam, we have already removed the main tumor and there is actually no disease seen by investigation. And we are only trying to treat the micrometastasis. So arbitrarily, it has been, there's no clinical studies on this, but whenever we deliver adjuvant treatment, earlier the better to get the advantage. And any patient who goes beyond 3 months, they are all excluded from trials of adjuvant treatment. So as clinicians, if 3 months have elapsed, but there is a specific reason and 3 months have elapsed, then we will consider. But patient is not coming, is taking time to decide. Generally, the benefits which we get is going to be small. Already adjuvant treatment provides less benefit to the patient. It will become much lesser. And hence we try to avoid it.
Thank you. So this adnexal mass, which we saw right in the beginning, we've been following her up as an benign adnexal mass through the pregnancy. She has a cesarean section for obstetric indications. Uma and Vijaya, what would you like to do? Do you just leave her alone, tackle her later on, or would you do a cystectomy or an oophorectomy on the table?
Because if it is a benign, but not sure 100% also, but LSCS, definitely we can do a cystectomy. No oophorectomy at the moment.
Okay, Uma, are you there with us? Dr. Uma?
She sent a message that the power is gone and so she's lost the signal and she's trying to log back.
Fine. So, Shruti, what would you want them to do a frozen section on this?
Yes. Once this cystectomy is done, it's better to send it for frozen section. Yes.
Okay, so sometimes the section may be at 1 o'clock in the night, and we may not
we just have to counsel the patient that she might need a secondary surgery if it turns out to be positive.
Right. So, and probably consent, etc. Right. And at this sitting, now, okay, it is in the middle of the day, and a frozen section confirms it is, malignant. Would you now advise a radical surgery at this stage? She just had a section, the baby is out, and we've closed the uterus. Frozen section has come back, malignant. So should we go ahead now, or can we wait for some time? If we can wait, how long do we wait?
We can wait, around for 2 weeks at least we can wait. There isn't a problem because they might have done a penile incision and so we might not have enough exposure through that incision. So we can give her 2 weeks time and then we can do a completion staging surgery later.
Vijay, are you happy with that?
Ma'am, why can't we do a staging laparotomy at the same sitting if it is a malignant tumor, if the baby is alive?
If there is a gynecologist on board available at that time, it's better to we have to involve a gynecologist at that time. If it is possible for to do that, then we can go ahead at that time. Or it's also okay to wait for 2 weeks. That's all. It's okay. We can delay for 2 weeks. It's not going to be a problem. But we can manage to do it that time, well and good. We can do it.
So the morbidity is not going to be higher.
Yeah. Yes, correct.
Okay. One question I forgot to ask you earlier, Shruti. You've been doing robotic surgery also. First trimester, does robotic surgery offer an edge over traditional laparoscopy?
Robotics is still a new kid in the block. So till now, there is no proven advantage over laparoscopy. So laparoscopy is better because there is no need to spend a lot of money over robotics in such cases.
Okay, I think that brings us to the end of our panel. I would like to thank Dr. Ramanan, Dr. Shruti, Dr. Purnima, Vijaya, and Dr. Uma. Yes,
if it's possible, I can. So when I went through the literature, it said that elective surgery is better than emergency surgery because in emergency surgery, sometimes it's shown that rate of spontaneous abortion and preterm labor is more. So the case we were discussing about the dermoid cyst, if it had been more than 7 centimeters and if we were suspecting torsion at any time, will you be offering her elective surgery or will you be waiting for postpartum surgery?
You are asking me or you are asking the other panelists?
Anybody. I think
Dr. Vijaya already said she would go ahead with surgery. So I think her opinion is clear. As I told you, I am sitting on her because she's got absolutely no symptoms. Torsion per se is more common postpartum rather than during the surgery. Because this, 5-6 centimeter mass, once the uterus starts going out, it's going to happily sit in a corner and not do anything more. There's not going to be an opportunity for it to tort at that time. So the chances are very, very minimal, and therefore I would definitely not subject her. Whatever said and done, there are anesthetic risks, there are surgical risks. And anesthesia also has been shown.
And also the laparoscopy, the pressure has to be very low and chances of hypercapnia, all those things are there. Still, a patient may go in for preterm, so many things are there. Maybe wait and watch.
Okay. Yeah, thank you.
So thank you, Dr. Jayarani, Dr. Rajeshri, and the entire Oxy team for giving us this opportunity. I've enjoyed doing this panel, and I'm sure my co-panelists also have.
Thank you, Jayashree, ma'am. Yeah. Thank you all.
Thank you so much, ma'am. Thank you.
Yeah, thank you.
Thank you, madam.
Yeah.
Thank you all of you.
Dr. Ramanan, Ramana Rajapath.
Yes, madam.
Bye, ma'am.
Okay.
Thank you, ma'am. Thank you, Rashmi, ma'am. Thank you, all of you.
Thank you. First of all, I would like to offer my gratitude to Almighty for guiding us in successfully completing the first webinar of Oxy Safe Motherhood Committee. I would like to profusely thank Dr. Jayarani Madam and Dr. Kundavi for creating these committees, pushing us to conduct more academic activities and providing the platform for the same. Dr. Shanti Gunsing Madam and Ramanan Sir, thank you for readily agreeing to participate and give your expert comments. Shanti Madam, you are a tall pillar of support for our committee. Thank you, Dr. Shravya, Dr. Asha, Dr. Sneha, for your practical approach in your deliberation and for making the committee proud today. And thank you, Bharani, for the enthusiastic compiling. Thank you, Jayashree Madam. Thank you so much for moderating the panel in your trademark style despite your flu. Thank you so much. And I thank the panelists, Dr. Vijaya, Dr. Umaram, Dr. Ramanan, Dr. Shruti, and Dr. Purnima for making the panel lively with your interactions. Thank you so much. A big thanks to Sheel, Chitrakala, Sahiti, and Suman for your excellent support for a smooth run. And I will be failing in my duty if I do not thank the audience for sparing their time and encouraging us. Savitri Madam, thank you, Madam. You motivate us. Once again, I thank you one and all. Thank you.
Thank you. Bye.
Bye. Thank you so much.